So, if you have any problems hearing, maybe with the presentation or something, just write here in the chat and my team will help you, will assist you, so everything to go very smoothly. Hi from Qatar as well. Please check the sound. So, please tell me yes if you can hear me. Who can hear me? Just please say yes. Let's check. Okay, so I have a lot of yes. That is good. Okay, great. So sir, I think it was a sir. You can disconnect and connect again. Maybe it was a problem there, as I can see a lot of yes. So I'm very happy to hear this. Great. So the chat is working. Now, the second instrument, very, very important, will be the Q&A, okay? Questions and answers. So if you see it down where you have all this like with the mute and the video and everything, and there you have Q and A. Do you see it? If you cannot see it, you will have the more button with three little dots. Just press that one and you'll have Q and A. Let's test this to see if this one is working, okay? Okay, how are you? Hi from Qatar. Question here. Great, Dr. Mohammed. Hello, Dr. Fatia. Okay, so hi. Okay, good. So you have the Q&A. So listen please carefully. The Q&A, please there write your questions that will be discussed at the end of the presentation, okay? So you can put there questions about your questions about, I don't know, yourself. You don't have to tell this, it's about yourself. I have this patient that has this. Okay, maybe it's for you. It's no problem. We are a lot of women here, so of course, we might have some issues that want to be practical for our own health. And the Q&A will have please the questions, and there please put the cases so it will be easy to discuss. For example, patient, I don't know, 40 years old, amenorrhea for 3 years, complaining of this and this. Sorry, I think something went wrong. Okay, so the patient, like 40 years old, amenorrhea for 3 years, complaining about this, what should I do, for example, okay? If the patient has some, maybe some cancer history or some treatment history or something, put it there. So it will be great to be specific questions, okay? Like to be clinical cases to discuss. So this we'll use for the Q&A. And this we'll discuss at the end, and we will take it in the order that you put the questions, okay? Good. Then, so this is the Q&A. It's for the long questions, please, like clinical cases. Good. Now, in the chat, okay, someone put here a case in the chat. Please put the case in the Q&A, okay? I see a 42 years old surgical menopause since 3 years. Very good. You put it very well. Just put it in the Q&A, please, okay? Not to be, because in the chat we're going to discuss during the presentation, we're going to ask you things to see about your level. You don't have anything you answer. It's not like a wrong thing. We just want to know what is your base level and what are you practicing in your country and what you are most interested in, okay? So in the chat, we'll write during the presentation. So if you write it here, please, Dr. Fatma and Dr. Nashin, write it in the Q&A, because if you write it here, we are going to miss some questions, okay? And we don't want that. Good. So we know how to use the chat, you know how to use this. Okay. Let's see, from where are you? Let's see. From where you are listening to us. There is no Q&A on my screen. Yeah, you have like a box with three little dots, 1, 2, 3 dots. More. Press the more, and there you will have the Q&A, okay? At more, if you don't have it on your screen. Okay, UA. Arlian. Al Riyadh. Riyadh. Okay. Germany, Egypt, Abu Dhabi, UAE, Italy, UAE, Dubai, Bahrain, UAE, Bahrain, Kuwait, Ukraine, Romania, Lebanon, Oman, Romania, Yash, hello, Dr. Ramona, Latvia, Dubai, Moldova, Mexico, wow, hi from Mexico, hola, ¿qué tal? Pakistan, UAE, Sudan, Saudi Arabia, Nigeria, Montenegro, great, wow, that is so great. Some good thing that the COVID brought to us, it's the idea that we can do these gatherings, these online webinars together. Remember, before COVID, we were not doing this, right? We are doing only live conferences, and if you could go in person there, okay. If you couldn't attend, too bad. But now look, we are here, and we can join from Boston as well. Hi, work in Kuwait but live in the USA. Hello, um, India, Macedonia, Bulgaria. So um, yeah, so this is a good thing, the good thing that COVID brought, teaching us how to use online meetings. And this is very, very nice. So now I want to invite Dr. Raluca Hera as well. So Dr. Hera, she is, um, I will say, one of the first, and not to say like the first doctor in Romania using hormonal replacement therapy. She has prescribed this since many years. She will tell you more about that. And Raluca, can you hear me? You can open your camera, please. Let's check if you can hear me. Um, Dr. Raluca, are you here? Okay, we're waiting for Dr. Raluca. Let me check about the connection. Dr. Raluca. Okay. So she has been prescribing this when first. I'm from Romania, Bucharest, East Europe. Hi. Romania, it's near like Turkey and Ukraine and Bulgaria, and then we have like Greece in the other side, and Italy and Spain. So Eastern Europe. Yeah, so when I was a resident, even like many years ago, and I was writing like hormonal therapy or menopause therapy, I found Dr. Raluca that was prescribing this and had a lot of, she has an institute, longevity institute, where she does as well longevity consultation, not only for hormones, but for rejuvenation, for therapy. Okay, just 1 second. Okay, sorry. I had to let in Dr. Raluca. So I had to fix that. Let's see. She was not able to join. She was hearing us, but was not able to open the camera.
Yeah.
Okay.
Okay. So here I am. Hello,
Okay. Yes.
everybody. Hi. Hey. Everything resolved.
Yes. Hi. Hi.
Oh, hello. Good evening, all.
Good evening. So I was telling to them that how many years of experience do you have with hormones?
So that was actually kind of a beginning of my presentation. I'm going to repeat it after that once again. So basically, I do that for about 10 years now. So I started 10 years ago. It was a very funny story. Like the patient who first came to me with some bioidentical hormones, and she told me like, can you help me get these? I had no idea what these were. She got them in a resort in Thailand where she was on vacation, and a doctor there gave her bioidentical hormones, and she felt so good. And at that time, she was already about 60 years old. Now she's 74. She's looking gorgeous. She was today in my clinic, and I always admire her, my first patient. So I started to read and to research about that, and it was really game changing for me.
Yeah, so
So
this
this
is
was
what,
10 years ago. Yeah.
yes, great. So, and this is what the patients actually tell you, that you change their lives. They don't, sometimes they don't recognize themselves during menopause. A lot of things change that we are going to address this in this presentation too. But after doing this treatment that is personalized and adapted to their own need, actually like optimizing what they lack, they feel more energetic, more concentrated, more focused, better at work, better in the with the partner, better in their with the sport, right, and everything. So this is what we want to promote. It's about like living long, but living long and healthy. And you know, like I want to be like when I was at the J Lo Jennifer Lopez concert, and oh my God, like she looks amazing, and with all the sport and everything. But for sure, I don't think it's only that. So yeah, let's see what until maybe some people are still trying to connect. We are here now 350, 355. Okay. We are going to wait a couple of minutes. Maybe Raluca, tell us about and to start with maybe an interesting case. So what comes in your mind? Maybe a case you have today or yesterday, to start with something to see how to we work with that.
Yeah, today I had really a case which blew my mind because I don't often have cases with primary ovarian insufficiency. And if I have, they're like around 38, 40 maybe. But today I had a patient coming in. She is 36 and had a primary ovarian insufficiency since 24. And this is really, I
Wow.
think,
She was
very rare.
24 years old. Wow.
Yes, and it was a natural ovarian insufficiency because I have another patient who had a bilateral adnectomy, oophorectomy for borderline tumors with 27. So she entered into surgical menopause. But this patient had really a natural menopause. And luckily, she was on a sort of a hormone replacement therapy, but already with osteopenia and a bit of disturbed quality of life. And these are really challenging cases because they are not standard cases, and you need really to know how to evaluate them once you come to you and put them on HRT as soon as possible, and
Yeah,
then,
and
of course, monitor them.
I see this more and more often, like I have, because I'm doing IVF infertility, and I see so many young patients, like before 30 years old, with ovarian insufficiency and menopause and perimenopause. And I always, first step, I give them the karyotype and the genetic test. And I have only one, I think she had like a Klinefelter syndrome, but the others, everyone did not have any genetic modification. Like, and they ask you, like, why, doctor? Why is this happening to me? And this is a complicated question, but what we can do is to ensure that they will have a good quality of life, because we have patients with osteoporosis at 30 years old. We have
Yes.
with coronary problems at 32. We have with damage of the mind, the cerebral activity at 35. So we need to take in consideration that menopause doesn't mean only the lack of menstruation. They say, okay, I cannot have any more babies now, and I don't have menstruation. No, it's much more for that, and we need to. This is what we're going to do now in this evening to understand how to see the body as like a holistic view, and everything is related to hormones. Even if you are doing like menopause treatment, IVF treatment, pregnancy, or any kind of procedure that you are doing, even like cancer, You need to think about how to what to recommend to the patient, like you said, after surgical menopause, what she needs to do after that, and don't leave it like this. If you take out the ovaries and put her in menopause, and yeah, save her life from a cancer, of course, but if you don't prescribe her what she should do or refer her to someone that knows this, you didn't do your job right. You save her for the cancer, but she will have so many complications during her life. Okay then. So I think we can
Sure.
start now.
Sure.
And at the end, we'll have the questions. So please write the questions in the Q&A, okay? And we have some surprises for you. So please stay here until the end because, we have Easter. In Romania, we're Orthodox, and Easter is in 2 days. And we want to give you some Easter presents for you as well, friends from all over the world. Okay, good luck.
Thank you, Diana, for this nice introduction. And I will start sharing my screen if it's fine. I hope this is okay. So can you all see my screen? Because now I'm just seeing my screen. I'm not seeing anything else. So
No, let me try again. Can you do it again? Put
yeah,
share.
sure, share now. Can you see it now? So
Yes,
it should be the title slide of the presentation. Can you see it?
yes, we see it. Is the maximum? Yeah, it's full screen.
Yes, yes, it's full screen. This is why I'm not seeing you at all.
Yeah.
Right now, I'm just seeing my screen. So it's HRT fundamentals in women, precision, safety, and longevity medicine. This is what you should see.
Yes.
Can you confirm? Yeah. So everybody's seeing and hearing well. Okay. Yes.
Yes. Yes. Yes.
Okay.
Someone says no, but Julia will take care. Okay. Who is no?
Okay.
Where our team will. But everyone. Yes. 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 Good.
Perfect, perfect. So again, thank you all, dear colleagues, for being here. And for those of you meeting me for the first time, I'm Dr. Raluca Hera. I'm a senior OBGYN. And like I said, for 10 years now, I am practicing just in a niche. I started with aesthetic gynecology and then expanded to menopause management and then to andropause management because the partners came in as well. Then extended my trainings on advanced hormone therapies and then on longevity medicine. And lately, I also finished my cognitive optimization program. So I basically am able to offer complex and holistic longevity protocols to my patients, women and men. And this is basically why around about 4 years ago, I am together with Dr. Diana Mihai, I started creating this educational track with webinars and courses for doctors because I kept seeing a gap between what our patients need and how confidently and safely the doctors are because they are not prepared to manage HRT properly. So what I want to offer you today is not a collection of hormone facts. It is really a way of thinking and implementing this concept of HRT for women and for beginners this time, and then maybe even more advanced. So a structured clinical framework who should allow you to use HRT with precision, safety, and long-term vision for the patient. Because as we know, a female patient enters menopause like around 50, 51 years, more often even earlier, and then she has another 30, 40, maybe even more years to live in menopause with disrupted quality of life if we do not intervene properly. And basically, the way we prescribe the HRT for a woman. And not only HRT, because if you do HRT, then slowly you start doing the rest, like supplements and longevity protocols, because it's emerging from that. And the way we are prescribing that is so important for our patient. It can either save her life. She, like Diana said before, she can benefit a lot from what you are prescribing her, or it can harm her. And we don't want to be there. So most of the harm doctors are doing is not intentional. It is because they lack structured education. And some of them have also updated dogma like fear and not enough information and or unsafe shortcuts, yes, because of lack of education. So basically, this webinar was created to rebuild the foundation of this concept of female HRT as a part of a longevity protocol, of longevity medicine, but it needs to be done with precision, safety, and responsibility. So I missed to show you this slide, which basically says the same thing about me. I have also finished a PhD in molecular medicine in Germany, in Munich. And starting 2020, I have developed Hera Medical Institute, private clinics in Bucharest, in Romania, and also in Zurich, in Switzerland. And as I said, right now, for 10 years, I am practicing the same thing over and over again. Management of menopause, andropause, longevity protocols, cognitive optimization, and aesthetic gynecology. So what I thought important to discuss today with you briefly is the current situation regarding HRT in the world. And I'm so glad you are from all parts of the world. And I will be so happy to have your thoughts about how is HRT in the country you are? How is that seen? How is that treated? What is the mindset of the doctors and of the health system in terms of HRT from where you are coming? I would also like to speak a little bit about the traditional health model versus the, how I call it, aligned health model, and I will explain it in a minute. Couple of words and algorithms about modern HRT protocols and why a holistic approach is needed. Because I am a clinician who sees this problem with HRT, menopause, suffering, and so on a daily basis. I see several patients a day. And because I am working at the intersection of gynecology and longevity medicine, it is this particular type of patients I am seeing, 40 plus usually. So this is why I would like to share with you this concept of HRT, which can sometimes confuse doctors if they are not well educated in this field, and of course, harm patient, or if not harming patient, then maybe worst case scenario, even the patient can leave your office without any HRT, which is the worst case, which can happen. And like I said, I see the same problems in my clinical practice every day. So women who could benefit from hormone therapy coming from other doctors who denied them the hormone replacement therapy out of fear and out of the lack of their education to a safe framework of HRT prescribing, no structure, no monitoring, no training on this. So I think the training on HRT, even for beginners, even if you have a training, a beginner training, you can start. I would also like to know who is already working with HRT from the current participants, and this would and for how many years, this would be very interesting for me to know, because maybe you are already qualified in prescribing HRT, but you have other questions or other cases to discuss. So I would really like this webinar to be interactive. I'm going to present briefly my part, and then I will be happy to answer your questions and share your topics of interest with you, and know more about you and your practice in this regard. What I also noticed is that if you are doing menopausal HRT, this can be an activity, an independent activity, an independent niche in itself. So you don't need to burn you out with pregnancies and births and other gynecological small stuff. If you can manage HRT professionally and confidently, you will have so many patients that you will not be able to address them, and definitely you will not need to do something else. So it is really a segment, a medical segment, which is emerging. It's a lot of interest, and nowadays, because FDA has removed this black box warning from the products, more and more patients will come to us. So what needs to be understood is that HRT is a part of a long-term vision, a longevity vision. And basically HRT is a neuroendocrine and longevity medicine. So tonight, I don't want to tell you what to prescribe. I'm here to show you really the clinical importance of HRT. So, why this webinar is, I think I already told you a lot of why this webinar is. We are dealing with a lot of patients in different age segments, starting from, like I said before, primary ovarian insufficiency, before the age of 40, premature menopause, then premenopause, menopause. So it's really an extended lifespan of our patients coming to us with menopausal symptoms. And we need to know how to implement HRT in each of the segment, because each of this life period has its particularities, has its characteristics, and HRT in premature menopause or primary ovarian insufficiency is not the same as HRT in postmenopause, of course. So I would like to come towards you with first with a general approach on how to manage these patients, so that I'm not telling you HRT is easy. It's just that you can do it safe, you can do it structured, you can do it in a responsible manner, and very confident in addressing the patient. So basically, everything I'm going to share today comes from a combination of my daily clinical practice and my several structured, advanced, really, trainings in hormone therapies and longevity medicine. But experience is also very, very important. And basically, I want to share the need to create more reproducible clinical reasoning for doctors like you who want to do HRT and want to do it well and confident and safe. So a lot of women in a lot of corners in the world, are trained, are undertreated or overtreated. And undertreatment or overtreatment is same as dangerous, because undertreatment basically leaves her without a brain, without the heart, like Diana said before, without a quality of life, without bones, and so on. And on the other hand, if we overtreat the patients, we can raise complications, yes, like bleeding, thrombosis, breast risks, metabolic damage. So both outcomes are dangerous. This is why we need to really focus on an optimal prescribing HRT. Not too less, not too much. And the truth is actually simple, because we as doctors, being gynecologists or endocrinologists or GPs or whatever, we haven't been trained to do that. I mean, at least I have fulfilled, like I said, my university in Bucharest, in Romania. But then I did my OBGYN specialty. Then I did my PhD in Germany. I've never heard about menopause and HRT during my training. I don't know about you. Maybe you can write in the chat. What about you during your training? So basically, what I knew about HRT was just hot flashes and fear of cancer. That was it. So, but then I started to learn how important hormones are. They're not cosmetic. You don't take hormones to look good. You take hormones to feel good, to be healthy, to live a long life. So to have not only a long lifespan, but a long health span. So it is very important. And in this respect, I would like to show you one. There are a couple of favorite slides of mine, like this one, for example. And I think in a lot of countries, HRT is not denied, but neglected. It's like something like a luxury, like nurturing, like pamperness, like what do you need? Why do you need hormones? So you're now in menopause, it's normal to suffer, and it will go away. And it isn't that if it doesn't go away, then take some plants and it will go away. And I see this in the traditional health model or disease model, like going to the doctor, treating symptoms when they occur, so not preventing something, but treating when the symptoms occur. Then you get drugs or even surgery. Like, for example, a patient in menopause who is not receiving hormones, she can become hypertensive, and then she goes to the cardiologist, and or this lipidemic, and it goes to cardiologist, and she gets antihypertensive medication and statins, and then she gets depression and goes to the psychiatrist and gets antidepressants. Then she develops diabetes and goes to the diabetologist or the endocrinologist and gets some medication for diabetes. Then she gets obese, and then she cannot move anymore. Then she gets arthrosis, and so on and so forth. And then she gets also brain damaged and gets Alzheimer's. And that's really a path which is not rare, yes, as we all know. And when she gets to the doctor, of course, she gets drugs, one size fits all drugs, because they're not personalized. Yes, treatments, medicine is not personalized. And of course, this cannot have a good outcome. As opposed to this traditional model, we have and we would like to promote as longevity practitioners the aligned health model, in which the patient prevents, or the doctor encourages the patients to prevent their symptoms, not to wait for the symptoms to occur, to optimize when lab tests are showing that, or hormone deficiencies occur, to optimize the patient, to counsel him regarding lifestyle changes, yes, cellular healing, detoxification, to personalize and customize the treatment, because we are all so different. And you can see for sure in your practice, like simple progesterone. You maybe, because you are probably most of you are gynecologists, you maybe prescribe like the universal utrogestan, for example. You prescribe it to one woman and she tolerates it well, and the other one gets retention or headaches, or her anxiety is getting worse, and so on. So we're all so different. So we really need to personalize the treatment, see what fits, what receptors does this patient have, and so on. So in the aligned health model, which is actually a model which promotes longevity and health, this should be a proactive health model. Yeah, proactive means test the patient before the symptoms occur and treat the patient holistic, not only for the symptom he comes for. Of course, lifestyle and epigenetic control are very, very important. And you will see this in my last slide. I have put something for you, which is very plastic, very very nice to remember and to talk to the patients, which I'm also doing, like things like sports and food and rest. This sounds so banal, but they aren't. Actually, it's the base for the patient. And on the long term, the proactive health model, the proactive management is actually cost saving, is more affordable. Yeah. Unfortunately, this is not a model which is covered by the insurances. So right now, for the patients everywhere in the world, this aligned health model is expensive. It's a luxury for a patient, unfortunately. But let's hope that things will get better. Okay. So, speaking of the global crisis of HRT, it's like I said before, the traditional model is actually the disease model. Symptoms occur, disease, you get treatment, and in the end, you will die. But the aligned health model, which we would like to promote, is working above the symptoms and even above the normal state, in the optimal state. And this is so important when you are looking, for example, at lab tests. Just give you an example, very universal example, like vitamin D, for example. Yeah, you see a vitamin D of 30, for example, or 25. And you see it's in the normal range. It's not outside, it's not in the box, it's not outside the limits. Is this an optimal value for vitamin D? No, it is not. You need to optimize the patient to get him or her to 60 or even 80, yes, nanograms per milliliter for vitamin D. So if a patient with a vitamin D of 20 or 30 is going to the GP, let's say, who ordered these lab tests, he says everything's normal, but our patient is exhausted, is getting frequent infections, has a poor sleep, has poor energy, and so on. So because he needs or she needs to get optimized her vitamin D levels, and not only. So this is why I want to emphasize for you, you can start today, look at these values in another way that you looked until now. Yeah. So don't look at normal values in the lab. Look at a more narrow range interval in the normal range. Look at the optimal range, which most frequent needs to be in the upper half of the normal range, most frequent. Okay, so what I see in the clinic a lot, these are some scenarios which I put together because they are so frequent. I see a lot of dangerous HRT from other doctors, patients who come from their gynecologist because they did not recommend HRT. I had 2 patients today, 2. Like in a day where you see 6, I don't see more than like 6 to maximum 8 patients a day. 2 of them came from their gynecologist because they did not recommend HRT. They said, you don't need that. It's risky, it's dangerous. So, and the problem is the mindset they are inducing in the patient. The other colleagues which don't encourage HRT, it's the mindset they are inducing. The patient is now so difficult to convince the other way. It's very difficult. So you really need to be very persuasive, very confident, and very responsible in what you are communicating to the patient in order to change her mind. It's very difficult sometimes. Then I have patients, for example, who come from their family doctor who told them not to take HRT under any circumstances because they will get cancer. This is also very, very dangerous, very difficult to change their mindset. Or patients who have HRT from other doctors but do not feel well because dosages are not well structured. Recommendations how to administer the product the respective hormone are not given. So often I ask the patient, okay, you have a gel or a capsule, or what did you have prescribed? How do you take them? How do you apply this gel? Where do you apply it? How big the surface you apply it? When do you apply it? And so on. And so often I observe these are details which have not been explained. So the patient does not really know how to put the gel on the skin. She puts like one square centimeter, and then she says, well, I'm having a big dose of estradiol gel, but it's not working for me. But it's not working because you're putting it on 1 square centimeter. How should this work? Because you need to put it on such a big surface in order for it to be absorbed. Yeah. Then another issue I am dealing with is how to collect the samples, the blood samples. Collection recommendations are not given. When should you take your blood samples in order to evaluate your hormone status, on hormones or off hormones? They are very precise instructions which you need to give to the patient. And yeah, ideally you should give them in writing, because when you talk to the patient in the office, she probably forgets 75% when she gets out the doors. If you talk a lot, there's so many information for her, new information, and like 75% is gone through the wind in the universe when she left. So you need to really be careful and give her in written as much information as possible so that she can recover it. And monitoring, then monitoring is also so important in order to have a safe HRT. Yeah. Then what I have seen again and again is, for example, transdermal progesterone with intact uterus. And maybe you know, or maybe not, but for a couple of years now, transdermal progesterone studies with intact uterus have concluded that transdermal progesterone is actually not safe for endometrial protection for a female patient who receives estrogen therapy and has an intact uterus. So you need to switch to give other ways of administration, but not transdermal. But a lot of patients are coming with transdermal progesterone, and then they bleed or they have a thick endometrium. So then what I see else, patients who have been refused HRT because they have comorbidities, also very important, like patients with arterial hypertension, high blood pressure, or diabetes, or even thrombophilia, or I don't know, whatever, you name it, other comorbidities, they were refused HRT. Oh, you cannot take hormones if you have these. Yes, you can. There are certain rules to follow when there are comorbidities. Each comorbidity, or endometriosis, for example, like pops up in my mind now because I've seen the case posted earlier on. We'll discuss it. So you can take hormones along with comorbidities, but of course you need to stick to some rules, to know how to monitor it, to know how to dose it, and to, of course, collaborate with the colleague, the other specialty colleague, of course, in order to conduct a proper treatment for her comorbidity as well. Hormone replacement therapy is not replacing the other disease treatment. Yeah. Well, ideally, it is that the patient comes for HRT before she gets the comorbidities, because the majority of cases, over 90% of the cases with comorbidities in menopause, are due to lack of hormones and lack of HRT. Yes, then inflammation pops up, lipids are going high, and so on. And then another category of patients are the patients who are reserved about HRT. Of course, there's another discussion. I am in the courses I hold, I am having a chapter about patients reserved about HRT. How are you dealing with these patients? How are you speaking to them? What exactly are you telling them? Yes, of course, in the end, it's her decision if she wants to take HRT or not. But believe me, if you can speak to them properly and confidently and responsible and based on scientific data, then a lot. So most of the patients can be converted to HRT-friendly patients. So, as a conclusion, I can say that unsafe HRT is very dangerous, while precision HRT provides protection for the patient and for us as well, of course, because we hold the responsibility. Yes, even if she's signing an informed consent for HRT, yes, our responsibility is to do the best for our patient. So the shift, like I said, hormones are neuroendocrine drugs for longevity. And they indeed are. And they are just a part of the protocols we are doing for longevity. Like a lot of years, like as I told you, I'm doing the hormone replacement therapy for 10 years now. And in the beginning, I did just simple hormone therapies, yes, like for menopause, estrogens, progesterone. Then I started also with testosterone, which is magic for women. And then from here, I did some more advanced trainings on other hormones as well. So I incorporated in my protocols also thyroid hormones. I address also the adrenal glands and brain hormones, all other hormones. So I extended, and then I extended to supplements. And this is where really the game changes, when you know what cofactors to administer when you're giving hormone replacement therapy alone versus when you're giving a hormone replacement therapy with the specific proper supplements. The outcomes are really very, very different. So the supplements you are giving play a huge role in optimizing this HRT you are prescribing. And then I did the longevity training. And I said to me, well, I'll do this training as well. So I get the longevity practitioner certification. But I already know so much. What can I do? What can I learn more? And it was really, again, a game changer for me. I learned about so many other segments of the longevity besides hormone. Like hormones is just a tiny, tiny piece. I learned of all hallmarks of aging. I started to learn about peptides, which is, of course, an evolving domain now, which is changing day by day. And starting to use them as well. I starting to learn about lifestyle, but very scientific. What can you do to improve your longevity with lifestyle? And it was really amazing. This training was amazing for me. And then, of course, the cognitive optimization, also a very interesting training with all segments you need to check with a patient besides hormones that can produce cognitive decline. Okay, so I deviated a little bit. Sorry about that, but I'm very passionate about what I am doing. So why do we say that hormones are really neuroendocrine medicine? Because in patients without HRT, we are noticing 3 major diseases. The big 3: cardiovascular disease, cancer, and cognitive decline. They're not the only ones, of course, you well know, but they are the major diseases which occur in most patients without HRT. So I would just briefly like to introduce you to the 3 main hormones, which I would advise you to start with prescribing if you are not doing it already, or refining your prescriptions if you are doing it already. But here, because it is a webinar for beginners, I would like to emphasize the very importance of these hormones like the estrogens, which are produced, of course, by the ovaries. And there are 3 types of estrogens. Yes, the estradiol is the most potent one, and 95% of it comes from the developing follicle. Then we have estrone, which is a predominant estrogen in menopause because it's converted from androstenedione in the muscle and adipose tissue. So it's a like spontaneous produced hormone in menopause. And of course, it is not so beneficial on its own. And we have estriol, which is the weakest estrogen, which normally comes from estrogen. So in menopause, if we do not do HRT, we mainly would have estrone, which is not such a healthy hormone. Yes, we all know that if estrone, or if you don't know, then I tell you now that estrone, if not detoxified properly, it has like 2 or even 3 phases of detoxification, and if not detoxified properly, it can accumulate and can cause DNA damage, can cause cancer, different types of cancers. So it's so important to control these hormones, even in menopause and even without HRT. Yeah, so this is why a lot of women with HRT develop cancer, even if they do not take HRT. And a lot of women because HRT is actually cancer protecting. So basically, a lot of women with HRT have lower mortality, lower morbidity on HRT because of the protective role of estrogens. And the roles of estrogens are basically, I named here just a few. Basically, each cell of our body has estrogen receptors. Different estrogen receptors, but they are everywhere. So estrogens control bone density, metabolic rate, insulin sensitivity. Yes, a lot of women in menopause not taking HRT with estrogen decline, they get belly fat, they get insulin resistance, they get weight gain, unexpected. They didn't change anything in their lifestyle, nothing. It's just the hormone deficiency. The muscle mass, the mood, the sleep, the concentration, then the blood vessels, very important, the endothelial quality, the arterial blood flow. That's why hypertension develops all of a sudden in menopause, even in skinny women. They develop hypertension when they are not taking HRT. Collagen production and maintenance in the skin, very important role of estrogens. Yes, because we will see later on in a slide the symptoms of estrogen deficiency with loose skin, laxity, and muscles. Normal blood pressure, memory, fine motor skills, and of course on a metabolic panel, homocysteine, which is a very important detoxification parameter, and lipid profile. And here is an image with a typical estrogen deficient woman, like over years. Yes, her everything is getting loose, her skin, her muscles, and on the inside, her bones. And then she gets low libido. She gets, of course, the dyspareunia because the estriol is missing from the genital area, and urinary tract infections and vaginal infections and depressed mood and dry thin hair and dry skin and brain fog, poor concentration, memory problems, emotional lability. The face gets a loss of femininity, like you see in this picture on the right. Yes, it's really towards a masculine image. Small, saggy breasts, then a lot of lack of energy, palpitations, hair loss, arthralgias, joint pain. A lot of women present with joint pain. So night sweats, hot flashes, these are classical. So sleep disorders. What about you? Maybe you can write in the chat, what are the symptoms which you encounter most often in your patients? Please write in the chat. What are the symptoms? Because if I would make a top 3 symptom presentation for my patients, these would be hot flashes and night sweats. These would be sleep disorders. This would be low libido and joint pain. I think these are the 4 top symptoms for my patients. And then maybe, they're equally important. I cannot make a top best, a top best, but maybe weight gain also. Weight gain is also an important symptom. Then we have progesterone, and progesterone is mainly produced in the ovaries and secondary in the adrenal glands. And progesterone has also a huge role in the body. It's not just compensating estrogen. It really maintains the health of organs and systems like the genital tract, yes, but also the nervous system, the breasts, preventing cyst formation when estrogen and progesterone are in balance, liver, kidneys, bones, immune system, cardiovascular system. It also improves sleep and anxiety and has a diuretic effect. And here is what happens when a woman is progesterone deficient. She is really pumped up. Yes, she gets large breasts. She gets a lot of fat. She gets acne. She gets hypermenorrhea or metrorrhagia, heavy and irregular periods. A lot of symptoms, though, are overlapping with estrogen and progesterone deficiency. So sometimes it is difficult to say if the hot flashes are really estrogen deficiency or progesterone deficiency, but it really doesn't matter because normally you prescribe them together. And there is, of course, known that progesterone is the hormone who starts to deplete first with age, like after 40 already starts to deplete, and testosterone, and then comes estrogen. So you need to correlate a bit the symptoms of the patient also with her age, yes. But anyways, we can have some overlapping, but mainly you can recognize a patient, progesterone deficient patient, when she's bleeding heavy, when she's bleeding also between periods, especially in this perimenopause time, when she has a lot of tension in the breast or breast pain, when she has pelvic congestion, she feels bloated and her lower abdomen is painful or sensitive. And when her sleep is poor, when she has anxiety, irritability, when she has mood lability, as mood swings. Okay, and then we have testosterone, which I really love very much. It's a hormone that is most of the time underrated in female HRT, and it brings magic into a female when, of course, prescribed correctly. And this is a hormone which also starts to decline with age, after the age of 35 even, because her mainly production site are the ovaries, and secondary production site are the adrenal glands in small amount. So with menopause, testosterone is also going apart, and it is very important in quite, I think, 4 main areas. Yes, it's bone density, it's muscle mass, it's cognitive function in terms of attention, concentration, focus, energy during the day, and last but not least, libido, sexual performance. Not so much, because in women, we are not going to prescribe high amounts of testosterone so that really she's impacted in her performance, but it can improve libido. So it's a very complex hormone, very beneficial hormone, and if prescribed correctly, 0 risks. Symptoms of testosterone deficiency are actually a bit overlapped with estrogen deficiency. So basically, we have low muscle mass, some muscle hypertrophy, we have skin laxity, we have droopy, thin hair, we have dry skin. confusion, brain fog, maybe brain fog and energy loss during the day would be and libido loss would be the three main characteristics of testosterone deficiencies, but also the other one I have listed here as well. And cellulite. Oh, yes, cellulite is one important symptom of testosterone deficiency, which appears out of a sudden in menopause. So just looking at these hormones who are declining in menopause, just estrogen, progesterone, and testosterone, we see the woman is coming into a state where she not only starts to look worse, she starts to decline in her physical aspect, but also in her health aspect, because like we have seen, all these hormones influence a lot all of the health and the good functioning of all organs and systems. So this is not menopause when these hormones decline and disappear. This is really endocrine aging, because we have looked now today just at these three hormones produced by the ovaries. But think about the thyroid, think about the adrenal. They are getting also older. They are aging as well. They're exhausting as well. So there we can expect also decline of the hormones. So put together the symptoms of all these hormones which decline during this after menopause, and there you have a really not so nice image of a woman in menopause. So this is basically not menopause, it's an endocrine aging. And our responsibility, if we get a good training in this field, is not controlling the symptoms, but to protect the next 30, 40 years, or maybe more, of our patient's life. Because studies nowadays show that genetically a human body can live up to 120 years. So it could be even 70 years where the woman needs to be protected by us. So precision changes really everything. If you know how to give hormones to a female patient, then her physical body, her physical face, everything will have another look. And you will not give her age. And I always tell that I want to, so I have a lot of patients with HRT. I mean, now I think I've really over 1,000 who are in my actual monitoring, active patients. And I said, of course, not all are in menopause, some are even younger, but I said I would like to do a photo with all my patients in menopause who are taking HRT from early entrance in menopause, which is really a very good moment, and make a photo with them and tell the age they have, and put them alongside with women with no HRT at the same age, and you would see a difference for maybe 10, maybe even 15 years of image between them. So it makes a really big difference. So what means a complete management for a patient which you think of prescribing her HRT? First of all, it's information. You need to talk to her, to inform her. They often come informed, but of course, you need to give them your specific information, targeted information, responsible information, and based on data. And then you will really be, she will really see you like an authority, because a lot of information can be nowadays taken from the internet or from ChatGPT. I mean, I have patients who are coming after having had treatments from ChatGPT for several months and they don't feel well, or they took some, I don't know, estrogel from their friends because their friends told them, oh, I feel so good with this one, try it as well, and they put it and they said, oh, I'm feeling so well, and they come bleeding then because the friend didn't give them the progesterone as well. They just give them the gel. And it's really very interesting what cases you can deal with sometimes, and I'm sure you have also such kind of cases. Would be nice to hear from you. But it's very important how you inform the patient about everything, about the good things that hormones can do, about the bad things that hormones can do if And if they're not monitoring, and if they're not controlling, and if they don't stick to a healthy lifestyle, and tell them that they also have a job. Yeah, they also have a job with a lifestyle. It's their job. And if they're not complying to this, then the hormones cannot do magic, or the supplements, and so on. So you need to have a discussion with the patient, a structured discussion. Yeah. So then, of course, after informing her, you need to support her in decision making regarding the management. Yes. Because more often the patients are asking, so doctor, what are you recommending? Okay, you told me about that and that and that, but what are you recommending? And that you need to be able to customize, to personalize the treatment. Then you can, then it's your rationale, how you see the patient, and thinking, well, this patient has this and this and this. What could suit her best out of all these options I gave her? Because of course she might be confused. And then, of course, you need to offer her a nice treatment plan, holistic, with hormones and maybe some supplements. Not a lot in the beginning. Maybe you cannot deal with, like, I don't know, high homocysteine. Maybe you don't know the protocol, because this is taught in the advanced course. No problem. But give her vitamin D, give her iron, give her magnesium, give her omega-3, give her the universal reset supplements in the beginning, so that she feels good. And she comes to you again, of course. So, but anyways, it needs to be an individualized approach, personalized approach regarding hormones especially. And then last but not least, give her the lifestyle recommendations, not in terms of, go and do some sports. No. How many times are you doing sports per week? What are you doing in these days, 2 days or 3 days? Can you do more? Can you do 4 or 5 days? Can you add some, I don't know, if she's doing weight training, can you add some cardio zone too? Or can you add some yoga? Or can you add, depending on the stress level she has and so on, you need to personalize. So what are you eating? How many meals are you eating a day? How's your sleep hygiene? How are you monitoring it? And so on. So you really need to be precise also with lifestyle recommendations, so that, and write them down, so that next time when she comes to you, you can make a follow-up, and then she can see it seriously. Like, you told me you do 3 times fitness per week, and I asked you to do 4 times or 5 times. How are things going now after 3 months? And then she says, that guy knows I'm going, he remembers. How did he remember? So she cannot cheat. But it creates a better connection between you and the patient, of course, and the results will be much better. Yeah. Okay, then if she has comorbidities, you don't need to neglect this. And usually I work with colleagues and I send them to certain specialists. I do not start an HRT protocol before having all medical reports from the colleagues, so that I make sure everything is very safe. And sometimes if I have doubts or questions, I just call the colleague and ask him, what do you say? Can we start on HRT now, or should we wait more? Or how's your how's your protocol doing with her? What are your plans, and so on? So it's very important that you don't miss up these comorbidities and the treatment plan. And then, of course, discuss treatment options with the patients, which, of course, we do not have time to go into detail here, because here are a lot of options to discuss. And after having established the treatment plan and the hormones she's going to take, counsel her a little bit in the end about benefits and risks of the specific HRT plan you have given her. And normally you can write something down which she can take with her or send her by email. Of course, talk to her in the consultation. But as I said, during the consultation, they all say yes. And then when they go away, they say, he didn't tell me that. He didn't tell me that. I didn't remember that. And then they mess it up. So basically, when you give them in written the things, then it's much, much better. So the key point your patients need to know when exiting your office after the first consultation or the second consultation, when you prescribe them already the HRT, is this. You need to reassure them that HRT is considered the most effective treatment for menopausal symptoms for most women. And then if they are an exception, then you discuss this exception with her. But normally, HRT is very safe for most menopausal women. And when you discuss the risk assessment, I will not go now into details. This is already a course chapter, but you need to address several things when you discuss the risk assessment. It's not only thrombosis and breast cancer, which they come with. They don't even come with thrombosis. They come with breast cancer. This is everything they want to hear, that they will not make breast cancer from HRT, which is obsolete, but you need to address it. So, but you need to take into consideration all other risk comparison factors, which I have mentioned here, like the type of progesterone you are giving them, natural or progestin, like the type of HRT, bioidentical, body identical, or synthetical, yes, the route of administration, yes, and what kind of hormones does she need, and discuss the benefits and risks. It's basically a brief overview of what you should discuss in terms of risk assessment, and what you should also evaluate in your mind. You should have this scheme in your mind when thinking about that specific patient. Where does she fit in to being able to recommend her the best therapy? So for beginners, you should stick to a very easy basic algorithm: 1, 2, 3, 4. Admission, of course, here you need to have a lot of other details checked, like a questionnaire, like lab tests, and so on. But see if she's a good fit, good candidate for HRT. Then assess her risk. This is the second. Like I told you before, in your mind, look up this patient first. What does she have risks? Does she have comorbidities? Where does she fit in? So I can give her HRT. Does she have any risk? Then do for her a personalized HRT plan. So how old is she? How much is she weighing? What lifestyle does she have? And so on. If she has comorbidities, to do something personalized for her. For how many years is she in menopause? I will not start with 2 milligrams of estrogen if she's already 5 years in menopause, because I would blow her vessels up. Yeah. So think about personalized HRT plan, and then monitor her. You give her a treatment plan. You say, okay, you take this, like this, like this, like this, and I'll see you in 6 weeks, in 8 weeks, in 12 weeks, depending on the patient and on the plan you have decided to recommend her. So what you need to understand in this is that this is not a prescription. Sorry about the letter missing. This is not a prescription, like you write, take. It's a path of clinical reasoning. The first you need to think, and it's quite challenging, and it's beautiful, because if you see the results, then you get more and more motivation, you get more and more experience, and you are better and better. Yes. And patients will come to you, will flow to you. Yeah. So this is what a safe HRT looks like. Yes, like I have described it before. Just 2 clinical cases to discuss. And of course, we will address your clinical cases as well in the end. But just to exemplify you how to think a case, like a case with insomnia and anxiety. She's in perimenopause and comes for sleep disturbance and anxiety. Yeah, she's age 47. She has sleep problems, anxiety, palpitations, did gain some weight. And she went, because of her anxiety, she went to the psychiatrist, and she was told she's stressed, and she was prescribed antidepressants. And the lab tests show fluctuating estradiol, because this is the pattern of estrogens in this age range, and progesterone under 0.5. So what do we do with this patient? Are we keeping her on antidepressants? Will antidepressants solve her weight gain? What do you think? Just write in the chat. Write in the chat and we'll discuss that. What do you think will this patient benefit from? Antidepressants, meditation, what? She's in perimenopause, she's got her hormones declining, so basically she does not need antidepressants. She needs a neuroendocrine stabilization with a bit of transdermal estradiol, just enough to stabilize her levels, her fluctuating levels, and a bit of progesterone in the evening for her anxiety and for her sleep problems. Monitoring, adjustment, and her life is changing in only 6 weeks after having started this simple treatment. Yeah. Then we have another case, a bit older woman with cognitive decline. She's already in postmenopause. She's 58. It's a true case, a recent case of mine. She's since 50 in menopause. Now with 58, she's coming. She didn't take HRT until now. She's coming with her daughter, who is very health conscious. She's a fitness trainer, her daughter, and her daughter is bringing her in because she thinks like when talking to the phone with her mother, and she's a bookkeeper, like she has an activity, yes, and sedentary activity, just say, sitting down on the chair in the office, doing no sports, eating not so much protein, and not doing any physical exercise. And she says, well, her mother is seeming like a bit weird on the phone, doesn't seem to remember things from one day to another, and so on. But beside that, she has also hot flashes, low energy, brain fog, which she didn't mention to her daughter. Her daughter just came because fear of Alzheimer's disease to her mother and some memory loss issues she remarked at the phone calls. And then upon speaking to her, we of course detected other symptoms as well. She is in menopause since age 51, had no HRT, and meanwhile, during these all 7 years, she developed high blood pressure, she developed diabetes type 2, and gained some weight. She was not obese. She's not obese. She's just overweight. And she was told from a family practitioner, I think, I'm not sure what specialty the doctor is, but it really doesn't matter because it can be any specialty, told her that HRT is dangerous and it's better to step off. And right now she's taking treatment for comorbidities, for diabetes. She's taking treatment for high blood pressure. And she has, of course, she's in postmenopause. All her hormones are gone. Everything is zero. Yes, is very close to zero. Yeah. So what are we doing with, what is the objective of treatment with this patient? It's a difference between 47 and 58, because at 47 you can still do prevention, while at 58 you cannot do prevention anymore in the aspects which are already degraded. You aim for stabilization, for hindering the progression of her problems, like you do some neuroprotection and cardiometabolic optimization, but the damage is already done. This, you cannot do anything with it anymore. So, of course, we started on estradiol, transdermal, small doses, and progesterone. Very simple, 2 hormones, and it's magic. Yes, she's not having hot flashes anymore. Her energy is really, she was like, after 3 months when she came, she was really another person. She started to do sports because she had the energy to do that. She's starting to eat healthier. She lost some weight. So her sleep was better. So it was really, really life-changing for her, and it still is. But we are now working on neuroprotection more with specific supplements. And of course, things are not changing from one day or another. But goal of this treatment in this patient is protecting her brain, especially. Yes, because at the age of 58, having already mild cognitive decline is not good. Anyways, in HRT, I think, how are we, Diana? I think I don't have long anymore, but is it fine if we surpass the 1 hour?
Because we have so many questions.
So no. Okay, so I will move quite, because
yeah,
doctors
have many questions, many clinical cases.
Okay.
So we have first something to, and actually I told them about our courses that we have. They
Okay.
asked about training,
Okay.
so
So
we
I will
can,
go through rapidly through the
yes,
slides. It's basically,
because they
this
are
is a
interested.
conclusion.
Yeah, they are interested about this the
Mhm, mhm.
mentoring and about the beginner,
Yeah.
the
Yes.
and
Yes.
then
Because this
let's
has
talk about the clinical cases because we have so many questions, and I'm looking forward to respond to all of that. Yeah.
Okay, so just keep in mind these steps. Just put it on a paper, and every time you see a patient, start to check these steps. Yes, just don't skip steps, because if you skip steps, then the mistakes come. So basically, like I said, it's a safe prescription HRT when it is done. When it is done responsibly, it is a deficiency in our medical education because we have not been learned about that. Most doctors prescribe HRT intuitively, no standardized algorithms, no clear safety framework, no longevity vision. So it's not a simple therapy. It's a clinical discipline, but if you master it, then it becomes very, very safe for you and for the patient. So, Diana, if you already touched the point with the clinical course for beginners, I will also present it briefly here. What we would like to do, it's really a HRT course for beginners. So what you have heard here is really just the tip of the iceberg. So female hormone replacement therapy as the foundation of longevity medicine. So basically we will enter into the course also into some small steps of longevity medicine in terms of supplements and lifestyle measures. Yes, not only hormones. It's a structured educational program for doctors, structured in 2 days for the beginners. And you can be a gynecologist, you can be a family practitioner, you can be an endocrinologist, or whatever doctor you would like to be to prescribe, or you have a contact with patients regarding HRT, you can join this course because it's a beginner course. It's really very intuitively, very basic, very, very interactive, a lot of clinical cases. And it is mainly addressing women, classical cases, so not like exceptional cases like this POI case with 24 years. No, we're not discussing these cases. We're discussing really basic classical cases of perimenopause and menopause. Like the most women are coming. Yeah. Okay, so there will be clinical algorithms, interpretation of lab tests, dosing strategies, monitoring techniques, safety frameworks, clinical cases, and you will also receive some materials hands out to ready to use in your practice at the end of the course. They are ready made for you and ready to use in the practice.
Yes, because
Okay.
doctors already in the chat asked about how to prescribe, what is the low dose, how to monitor. So this in the beginner's course, you will have all of that.
Yeah.
And they ask about the clinical cases. I told them that we have at least like 40 or more clinical cases
Yes.
from where you will learn. Yeah. So you'll have all
Okay.
of that there.
So we will basically focus on safety first, yeah, and then extend to longevity protocols. Yes, it will be, of course, a medical approach, protocols that immediately are applicable in the clinical practice, because you will see, we will discuss, as Diana said, so many cases that you will need to interact with us and really write the prescription. After the theory chapter, you would get clinical cases and you need to write the prescription for that patient. So you will practice a little bit during the course already. Okay, and beyond the course, there will be clinical guidance in the application of HRT algorithms, clarification of real cases from practice, if you have cases to discuss, of course, or yourself. And this is an advantage for your development, of course, of your clinical competence, because you ultimately can leave apart everything you're doing in your gynecology and obstetrics field and do just that, because you will be loaded, trust me. And of course, you will have access to a professional community oriented towards excellence, really. Really, I have trained with the leaders in this field, in every little field. So I did not train hormones and longevity with the same trainers. I choose and cognitive optimization. I choose the leaders in this field to train with, and this makes a big difference. So what is the course? This is the course. We basically organize courses for beginners and courses for advanced doctors. And you can also purchase the package. There'll be educational materials. Like I said, there'll be a professional certification and the post-course support. The standard rates for the courses would be these. We have chosen, it will be an online 2-day course for beginners. We have chosen the dates of May 8 and 9. And for the advanced training, the days of May 15 and 16, so the week after. And after this webinar, we would have special offer for purchasing one or both courses. Either way, there is an offer 48 hours after the webinar, and this would other rates for the post webinar purchasing during the next 48 hours. And we will focus on, like Diana said, we will apply the discussions to real cases. We will focus on clinical interaction, exactly how to prescribe, what to analyze in terms of risks and so on. We will focus really on quality, depth, not on volume. We will repeat the same things so that when you go out of this beginner course, that you will know what to prescribe to a patient. And then we would have a clinical mentorship for 20 physicians. This is, I think, with the package. Sorry,
Yeah.
I'm not sure.
So
For
it's the most amazing part because like what usually is our problem, and my problem was as well, or our Lucas problem when we first started. You go to a course, you learn the theory, then you learn some clinical cases, but then you are face to face with your patients and you face some problems because the patients are different, have different comorbidities, have different lab tests, have different symptoms. And the amazing thing is that you'll have this, the first 20 people will have the mentorship. So if you will buy the beginner and the advanced, you package together, you will have mentorship.
Yeah.
What's the mentorship? This means that, look, you'll have sessions, online sessions with Dr. Raluca Hera monthly to discuss about your cases, what to do, how to monitorize what is your problem, and how to be more confident in what you're doing. And I think like this is the real great thing that we have. Because and that's why we keep it limited for the first 20 people, because after that, if there are like 100 people, then you will not be able to put questions, and you'll not be able to listen to everyone, to have the discussion. So 20 people, restricted group, so you'll have the best of the mentorship. You can ask things, discuss cases, monitor along with Dr. Raluca Hera from session to session to see how the patient is going, to know what to do next. Maybe you have like some problem from the patient, how to get some advice. And yeah, so this is for the first 20 people, because yeah, we need to have very good quality. We want to give you, we always organize very good quality courses, so to be practical, to help you in your day-to-day life, to help you with in your clinic from the next day that you go there, not only to have like theory, or no, theoretical progesterone does this and theoretical testosterone does this, and it's a great thing to combine them, for example, right? We need to see exactly how to do it in your practice, from where to buy the hormones, how to do the consent, informed consent of the patient, how to make the questionnaire, what to ask the questions, how to see what they should do, what they should what blood test they should do. Yeah.
Yeah, and I think coming back to this slide, this is teaser for you to think if this course is for you. Put yourself these questions. How many patients present with symptoms of hormonal deficiency in your daily practice? What percentage of patients would benefit from a comprehensive hormonal evaluation in your practice? How can you optimize your patients' quality of life in the long term? So if you deal with patients where you set yourself these questions, or they come to you with these questions, then you definitely need to make this switch, this medical education, further medical education, in my opinion, to get this clinical competence. So just briefly, some testimonials from some of my patients. I have them on my website because I am very proud of them, and because I just want to show you how quickly they improve with HRT. It's, if you read through the lines, you will see like 3 days, 2 weeks, 1 month. So it's really magic how quick they recover, and their quality of life is changing after starting on HRT. So these are some testimonials. So concluding about the course, again, we've put together here the standard rate and then the preferential rate, 48 hours after the webinar, and the exclusive package, which is value of 500 euros, but is not to be paid for these ones who are getting the complete package. They enter in a small group which will benefit from private sessions, 5 private sessions with me after the course. And the dates also. So hormone replacement therapy is not just about hormones. It's about, like I said, protecting the next 30, 40 plus years of your patient's life. I will finish with some diagrams, which I love a lot, and I talk about them in the course regarding lifestyle and how you should counsel your patient regarding lifestyle, sleeping, fast diet, exercise, and about the brain food pyramid is on the right. And I am concluding here, and thank you so much. I'm sorry I have been a bit longer than 1 hour.
No problem. It's been very interesting.
And
but,
I'm happy to answer some questions.
Yeah, this will be the most interesting part, of course, because we have so many questions. I will take them in order.
I will stop sharing, yeah? I will stop sharing now.
Okay. Yeah. So I will go to the Q&A. You want me to read them, or you want to?
Yeah, maybe you select them so that I'm
Okay.
not sure I will be able
Yeah.
to select them so quickly.
Okay. So I want to know what is the proper level of estrogen in the blood to have the benefit of HRT. Not only symptom relieved, but also bone support.
So we like to keep it between 40 and 60 for most women, but there are some women who tolerate more. For bone support, around 60 is fine. If the woman can support more, like up to 75, it's even better. But 40 to 60 is a fair level of estradiol on HRT.
Mhm. How can we start HRT in women at age 45, but having symptoms like loss of libido, hot flashes, low mood, anxiety, but periods regular?
Yeah, probably a hormone status with estrogen, progesterone, and testosterone would be useful in order to decide what to start with and see how they are balanced during the same cycle phase.
Okay. For how long after menopause we can prescribe?
This is a chapter which we discuss in the course. It's called the window of opportunity. So theoretically, it's up to 10 years after entering the menopause.
Please guide from start how we can start HRT safely and conceal women and which test to do.
Yeah, this is a course.
It's very long.
It's a lot to, yes, exactly. It's a lot to say, but I encourage you, if you have these questions, then you have a plan. So it's probably a good idea to take the course, because these are exactly the ideas we are discussing in detail in the course.
Mm-hmm. Yeah, because how to start safely depends on the patient and depends on the comorbidities and depends on the test. So this we are going to discuss, and it's not like a general answer. Even for cancer survivors, we have a part of the course with for cancer survivors, and this is a lot of discussion too, because it's not contraindication for all patients, but only for some of them. And you'll be surprised that you can actually prescribe hormone replacement therapy for a lot of cancer survivors. We had some questions about PMS as well, and you told us, and we have a part of the course about PMS, premenstrual syndrome, and premenstrual depression, and
Dysphoria.
how to improve this with dysphoria. This was the dysphoria. And as well, we had here questions about treatment for endometriosis, and it's very important to know how to use the treatment, because you want to protect this lady that usually is very young with endometriosis, maybe with ovarian insufficiency after surgery. And at the same time, you don't want to have relapse of the endometriosic tissue. So yes, you can use it. We recommend it. It's very good, but you need to adapt it correctly. Okay, two
Yes, even
questions.
in
Since
postmenopause.
their
Yes.
data Okay. Since their data for HRT for preventing bone loss and cognitive decline, do you recommend using it for patients for something osteoporosis or dementia?
So here things are very clear. Osteoporosis is a primary indication. Preventing osteoporosis is a primary indication for HRT. So we give it definitely in younger women. It's the first option treatment for prevention of osteoporosis, while estrogens are not indicated formally for cognitive decline. So they can prevent cognitive decline, but we do not give them for cognitive decline because studies do not show or are quite contradictory that they really can prevent cognitive decline. So it's not a primary indication.
Okay. Any data to use cyclic estradiol and progesterone to imitate physiology instead of continuously to prevent receptor desensitization from continuous use? So like to
So
use very short, when you use cycle, when you use continuous.
yes, it depends on the age of the patient. It depends on what the patient wants, but we can definitely do either cycling or continuous, but this is personalized. We need to judge the patient, but definitely possible.
48 years after TAHBSO, what is
Total
total
total hysterectomy and
and expected
adnectomy. Mhm.
after diagnosed endometrial cancer with hot flashes?
Yes, depending on the stage of the endometrial cancer. So you do an evaluation. Endometrial cancer per se is not after treatment, of course, is not
After
a
surgery.
contraindication. It's not a contraindication for HRT. But
Exactly.
depending on the stage, yes.
Yeah. So most of them don't. Some of them you need to be careful, and some of them, but we have this about the cancer. But it's not, just to know, like it's not a 100% contraindication at all. I had a patient with iatrogenic premature ovarian insufficiency, now early 30s, bilateral oophorectomy for borderline ovarian tumor. Do you use the treatment until natural menopause?
Yes, this is how it's indicated. Of course, ideal is that she continues the treatment also after the natural menopause, but the protocols are indicating like a mandatory treatment until the age of 50 to 51. Yes.
Yeah, so mandatory until that, but not only. She can use it for how long? For
She
as
can
long as
use
she
it
wants.
until the end of her life, how long she wants to live.
Exactly. So this is another thing, because before it was like, oh, only until 65 or only until 70, only until 10 years. No, you can use it. Usually we are scared before prescribing. A lot of doctors said like the lack of protocols and legislation is a problem, and they would really use some protocols to be safe. So we are scared to prescribe HRT due to the side effects and patients lost to follow up. So you don't give the patient the hormones for long period. You always they need to come back to have a new prescription, and you don't lose them from follow-up. If they don't come back, they will not get, how you say,
The
the prescription.
hormones, the
The hormone.
prescription, that's correct. Yes.
What do you do regarding the issue and when to prescribe HRT if we know patients will not follow regularly? So
Yeah,
this
they lose basically their treatment plan. Yes, because
is
luckily hormones cannot be issued from pharmacies without prescription. Luckily, so you need to, if you don't monitor them, if they don't come to you anymore, then they've lost their treatment.
yeah, so at first you give them hormones for about maybe depending on the symptoms, but usually for 3 months, you see them how they react, and then you give them for 3 to 6 months, and then at every 6 months you do evaluation, and once per year you see them physically, right?
Right, correct. Yes, that's the
Like
most
most of
case
the,
scenario.
yeah,
Yes.
classical one, let's say, adapting to everyone, of course. So, what is the difference between traditional HRT and bioidentical hormones?
This
Shortly.
is also a course chapter, but mainly traditional HRT is synthetic hormones. Bioidentical hormones are the ingredients, the raw ingredients are from plants, but they're still hormones. They have the same benefits and the same risks with the synthetic hormones, but they're more physiologic for the body.
Yeah,
They're
exactly. Like, for example, progestins about the risk of breast cancer and other things, progestins versus micronized natural progesterone. So they don't have the same risk on the breast, and even the opposite thing. Progestins increase the risk, and natural progesterone, even in some studies, show that decrease the risk. So, yeah, this is the difference. 50 years old single woman underwent hysterectomy with bilateral oophorectomy, I think, due to multiple right fibroids. She developed multiple DVT post-operatory.
mm,
She received therapeutic treatment and now on prophylactic enoxaparin. She's suffering from severe hot flashes, so 50 years old. What are the HRT choices for her?
Yeah, of course, after thorough evaluation and a multidisciplinary consultation, counseling with the team which is following on up her DVT, you can start on transdermal estradiol, which is basically not rising her thrombosis risks more than the basal population. It's like transdermal is very safe, and you can apply it. But again, of course, this is a general principle. It's not a contraindication. You need to monitor to evaluate the patient thoroughly before coming to this decision. But it's not contraindicated.
Okay, so okay, so congratulations for the doctors that already purchased the course. We'll see you online. By the way, if they are not able to be there online in that dates, they can see the recording as well, right?
They can see the
Yeah.
recording. Yes,
So.
yes, of course. Yes. This will be available for a period of time after
Mm-hmm.
finishing
Yes.
the course,
So
I think. Yeah.
yeah, it will be online, so you can see it after that as well. Yeah. So congratulations. Registrations are open now. You can use the chat link to register because you asked us about the course registration. So you have there in the link. If you don't see it and if you don't find it, please write down and you will get the information. Okay, so next case, 54 years menopause since age 46, just starting getting hot flashes and night sweats since 2 years. So 54 now, menopause from 46. Now she got hot flashes since 2 years. She is hypertensive on treatment. Also loss of libido, mood disturbance, and dull skin. What is the best HRT?
Probably you can start with a classic HRT of low dose estradiol and natural progesterone and see how she evolves. But in parallel, she needs to follow up her high blood pressure treatment. So you can start on low dose. It's no problem.
What combination would do, for example?
For example, you can start on 0.5 milligrams of an transdermal estradiol gel and 100 milligrams of natural micronized progesterone every
Would you
day.
use, would you use some DHEA as well for libido, or vaginal or oral?
So DHEA, I would first dose. If I would have to administer it orally, I would dose the DHEA first and see if she is really in a very low value. Otherwise, maybe a DHEA vaginally you can always recommend, or some vaginal estriol. Nevertheless,
And
these
would you on
are
testosterone with in
Yeah,
combination?
nevertheless, these vaginal remedies will probably not help her with her libido. They will help her probably more with her sexual dysfunction, because probably she has vaginal dryness and she has a sexual dysfunction and consequently low libido, or vice versa. But anyways, for libido, maybe you could take into consideration also some testosterone, yes, but also upon dosing, not beforehand.
Okay. Let's see. Post hysterectomy with bilateral ovarectomy, 44 years old, for endometriosis. Which HRT types will be best?
She needs, definitely, because she's very young. She has a premature surgical menopause, and she definitely needs HRT. And she needs quite high doses of HRT in this age to prevent osteoporosis. So probably 1 milligram, starting with 1 milligram estradiol already.
Mm-hmm. Um, I would like to get opinions on whether generally prefer HRT as transvaginal or transdermal. I need opinions for my research.
Estrogen,
Generally,
vaginal or transdermal? This is the question.
yes.
So there are basically different objectives of treatment. With vaginal estrogen, you get relief of the genitourinary syndrome of menopause, while with transdermal estrogen, you get systemic effects of estrogens. So you can use them in parallel, both, but they have different actions.
Okay. So if she needs transvaginal, will help her only for the vagina symptoms, dyspareunia, dryness. Transdermal will help her with the vaginal symptoms maybe as well, but with her systemic symptoms. So depending on the patient, they say like generally prefer. It's not generally prefer. It's according to the patient symptoms and age.
Symptoms, right, right. So
45 years old, surgical menopause due to BRCA, and undergo TAH, BSO due to strong familial breast cancer. She took HRT with estrogen for 2 years and stopped since 2 years. So she's 45. Now thinking of restarting HRT as she feels very low. What are the pros and cons, and for how long? What should be the follow-up plan? Like, should she take more or not?
yes,
So
either
only
BRCA
give
or
this as for example.
yeah, either BRCA positive or at high risk without having tested for BRCA, but she's well more advanced, are no contraindications for HRT and do not pose the patient at a higher risk of with HRT. So it's basically a classic HRT for her with thorough monitoring and no contraindications for her. I don't see any.
Mm-hmm. Okay. So Yeah, we saw some doctors that register for the advanced course. Okay, so if you register for the beginners, and the beginners will be very clear, even if you are already using BHRT, actually know that it will be a lot of information. I always, every year, I go to the beginners course with Dr. Hera because we organize it together, and I listen to her every year, and still. Even if I'm already doing hormone therapy for a couple of years, still I learn new things. So it's not really like beginner, but it's a foundation, and you need to have like a strong foundation to build up the other information. This is for like doctors that ask me if they should take the beginner class or the advanced class if they are already prescribing HRT. So my recommendation would be to take both of them. We had doctors and we asked them and said like even they are already doing it, it was more clear now after the course, and none of our doctors say that it was for nothing. None of them. Yeah.
Yeah, because in the beginner's course, we will really address the basics on what to prescribe, doses to prescribe, effects of hormones, hormone deficiency, hormone excess, and so on, and diagnosis methods. While in the advanced course, we will not address these things anymore. We will just come up with complicated cases, with special particular cases, with special cases, basically, and how we manage the HRT in these cases, how we monitor them, and so on. So we will not tell again about the facts that we do in the beginner's course.
Yeah, so in the advanced, you already have everything well established, doses, monitoring, how to give the consent form, how to make the charts for your patients, the questionnaires, the informed consent, everything of that you'll have in the beginners. And then we'll discuss complex cases in the advanced. So we'll not go again with all the things from the basic one. Okay.
Yes, even in the discussion with the patient in the beginner's course, we will address simple discussion with the patients, like about what is HRT, how to explain a patient what is HRT, what she could expect as benefits and risks, and so on. These things we will not repeat in the advanced course. In the advanced course, we will repeat communication with patient regarding complex risks, regarding informed patients, for example, who know a lot and come with studies to you and ask you about, I don't know, the WE study, for example, and you need to explain them. So more complicated things, but also in terms of communication with patient, but not basic things.
Yeah, because a lot of you said that the patient, when you ask what is I ask about what is the biggest problem that you have prescribed in this, was that patients are reluctant and they are afraid of using HRT. So I think that if you don't have this, a very clear protocol, how to address it to your patient, how to make them feel confident, then and how to explain and to give them the materials to read at home and to study and everything like that. You can know all the complex cases, but if you don't know how to communicate with the patient to be medical legal okay as well, like not to have any problems on the legal part as a doctor, like, oh, you didn't inform me this, because you cannot inform the patient with like in 10 hours, like to explain all the risks in the world, all the benefits in the world. So you need to make a plan for that. So the patient will not say after this, oh, you didn't inform me about this, or I have a problem understanding this. This is a very important thing. Okay. 34-year-old patient. She has low total testosterone, low DHEAS, and low ACTH with normal FSH, LH, prolactin, and TSH. She complains about vaginal dryness, low libido, night sweats, fatigue, and trouble to sleep. What should I prescribe? So 34.
Yes, but I don't know how the other hormones are, like estrogens and progesterones during, like, for example, the luteal phase would be interesting to see, maybe two measurements apart, 2 months apart. Anyways, if total testosterone is very, very low, of course, you can start on low dose testosterone. And she might have relief of her night sweats, for example. She might have an improvement of her libido as well. And DHEA is also an option, and you can go along DHEA with testosterone. They're overlapping just a bit in the effects, but DHEA is a pro hormone, yes, and it's helping the production of the other hormones. So she might get a benefit in the estrogen production, for example, upon administering DHEA, and it also has a slight positive effect on the libido. In a longer time than testosterone is spiking, is better in terms of libido improvement, but it can help. It can help.
Would you give her only like testosterone gel, maybe like 0.2 or 0.3, something like that? Or you would
Yes.
combine it with maybe estradiol or estriol in the cream, like you can give it alone?
You can do it, but I probably will not. If she's menstruating regularly, she has a low FSH. Most probably, I don't know her estradiol values, but most probably she does not need estradiol at this age. Most probably. So I would probably start only with testosterone first.
Okay. If patient came at around 55, not taking before HRT, menopause, how we can prescribe her HRT?
Like so. So starting with a low dose, even if she's like 5 years in menopause or how long, starting with a low dose, always um, low dose starting. And so go slow,
Yeah.
and 0.5 would be a good option, even if her symptoms will not relieve completely 100%. You can reevaluate her and adjust the doses after that. It's better than starting with a higher dose.
Okay, 51 years old with endometrial cancer under THH with BSO, which would be best HRT?
Like I said before, endometrial cancer is not a contraindication if it was a good stage when operated and she has nothing left from her cancer, which you can check on a PET CT or MRI, then you can safely start a standard HRT.
Yeah, depending on the type of endometrial cancer, someone says like estrogen receptive positive is a contraindication for HRT.
If the cancer has been removed entirely and you have an evaluation head to toe that nothing is there, you can start on HRT.
Yeah. Okay. Is wild yam cream effective in menopausal symptoms?
So wild yam is actually the origin raw material for the bioidentical hormones, yam's root. But yams is then processed in the laboratory to become a hormone structure. So yam is a sort of phytoestrogen. That means it acts on may act, not necessarily, not in 100% of the cases, but it may act to relieve vasomotor symptoms, to improve some sleep, hot flashes, night sweats. But it just acts on the tip of the iceberg in terms of modifications in menopause. So it's not a hormone by itself.
53 years old, HTN, dyslipidemia, hypothyroidism, post-hysterectomy. Would you advise HRT,
Of course.
workout, and FU? I don't know what is exactly F. Okay. Yeah, so if she has
Of course.
hypertension, dyslipidemia, hypothyroidism, yeah, we need to address her to see exactly the evaluation, to see her optimizing her dyslipidemia,
Comorbidities.
comorbidities, exactly. And then she can use it. Like, but
Yes.
Dr. Raluca always, and this is what you will, she will teach you as well about the supplements, about the vitamin D, the ferritin, the homocysteine, the omega-3, the a lot of other things that will help her besides hormones. So it's about the longevity and addressing the comorbidities and the insulin resistance and all of that, the thyroid as well. We will discuss about everything because everything is related. And we don't talk only about like how much estrogen, progesterone, and testosterone you will prescribe, but how to combine it with supplements, nutraceuticals, and longevity and biohacking things as well. Someone asked about amino acids too. We talk about
Mhm.
proteins, about amino acids, and all of that because all goes together. If you use only the
Yes.
hormones, like you said, it's not enough.
And paradoxically, HRT, once starting on comorbidities, is improving sometimes the comorbidities. Patients sometimes go off antidepressants, lower their blood pressure therapy, lower their diabetic medication because hormones help improving all these metabolic disturbances.
Mm-hmm. What do you think about progeluton medication as HRT?
I'm not sure I know the product. I can look it up and maybe send a reply later on because I need to look up. I don't know the name of the product. It's not familiar for me. I don't know in which country it is available. We don't have it available I mean in Romania and even in Switzerland. I don't have it there, so I don't know the product.
Okay. Someone asked about best course or certification for menopause management for doctors. Okay. We
So
have,
I don't know which the best course is, but
yeah.
what I know as a feedback from former doctors who took the course is that they have looked up really internationally for a course on menopausal HRT from A to Z, like in terms of how do you get the basics as like deficiencies, hormone deficiency, what to prescribe, risks, and so on, all algorithm going through in a course, like I briefly described in this webinar, and they couldn't find. And they were very happy with this course because it just takes you from A to Z. When you finish this beginner course, you really go in your office and you can really write a prescription and evaluate the patient.
Exactly. Everything will be very practical. What do you think about HRT in perimenopause, age between 45, 47 years, complaining of fog, fatigue, bad quality of sleep, but still has period? Like, how would
Yes.
you give it?
Yeah, I would probably in this situation I would evaluate it. It is an age where estrogens are fluctuating, so she might have better days or worse days. She probably needs already optimization with estradiol as well, definitely with progesterone. But why would I do a hormone status? Because normally you don't need to do a hormone status to diagnose perimenopause. So I just want to make sure she has not unbalanced estradiol values, like in terms of hundreds, where of course I cannot optimize. I don't need to optimize her. I would start then only with progesterone. So I would do a hormone evaluation and see I'm starting her either on progesterone alone or on both.
Like progesterone 10 days per week, 12 days per week, per month, or
Well, depending if
all
she
day?
has sleep problems, I want her to sleep every night good. So I would give her permanent, not only 10 days, because then the other days she would not sleep well. So depending on the main symptoms. If her main symptoms are, I don't know, cycle irregularities, then I might think to give her cyclic progesterone. So
No,
it's
like,
very
yeah, her main
variable depending on the symptoms.
fatigue and bad quality of sleep. So that's why I ask about continue.
Probably I would give her permanent,
Mhm.
small dose.
How does HRT directly support dopamine and executive function in ADHD patients? Are there specific hormonal targets or delivery methods you recommend for these cases?
So there's of course a connection, but HRT is anyways beneficial for these patients, but not specific. But in dopamine issues, serotonin issues, ADHD, you need to look up other things. Like I told you, cofactors on hormones. Like for example, you need to definitely improve methylation. This is a key factor in ADHD and dopamine disturbances. So there's quite a protocol for improving methylation, to check methylation first in her lab tests and then improve it. And you will probably see benefits along with the hormones, but not hormones specifically.
By the way, like congratulations for the other doctors that just registered for the course. Hey, so actually, what just a little phrase about methylation for people that don't know what is this methylation.
So methylation is a phase 2 detoxification process of hormones and of other products. So it's very important. It depends on several cofactors like magnesium, B vitamins, zinc, glutathione. And if these are not optimal, then methylation process is not optimal. Then products which are not methylated are accumulating and create other disturbances.
Yeah, we will discuss about that as well because it's very interesting. So we're not going to talk in the course only about estrogen, progesterone, testosterone, but about the methylation too. And actually, like some doctor asked about the metabolites, and we will have a course on the Dutch test and about metabolites. We will address it in the advanced course too. But we will have a specific course like about the Dutch test. Do you know about the Dutch test, right? And about the metabolites of estrogen and how to interpret that and how to modify the treatment plan of the patient according to that. So this is an advanced part two that we're going to
Right.
discuss. I am 49 years old. Hello. Last born 9 years ago. Doesn't have any medical problems. Have regular periods. No hot flashes or any problematic symptoms, but have low energy, mood swings, skin and hair problems like hair fall and acne. I want to start hormone therapy. What are best choices for me?
Best choice is first do a lab test. Do some lab tests to see what the imbalances are because they can be on an estrogen, progesterone, testosterone level. But as you tell, the symptoms, they can be also on the thyroid level and on the adrenal level. So I would first do an evaluation, not only hormonal, it could be also iron deficiency, what you mentioned in terms of fatigue and hair. It could be, so do a comprehensive lab test evaluation, including hormones, and then we can set you up.
Yeah, and ferritin level and
Yeah,
methylation and all of this. So it's very interesting because so many people are complaining about this like low energy, burnout, and it should be a combination of improving hormones, improving lifestyle, and optimizing many things. So I saw a lot of patients, for example, folic acid, like don't
right.
take normal folic acid, take active folate.
5-MTHF. Yes, it's a
Yeah,
methylated form of folate.
and
Yeah,
test it as well, like see test it in your blood and to see the level of folic acid because so many people is like very very low, and we don't need it only when we are in like pregnancy. You need it all over your life, even in menopause. And homocysteine
correct.
level and vitamin D, like you said, it should be like 60 or more, not you see it 20 and like, oh, I have optimal vitamin D level, why I'm not functioning well. And actually like vitamin D is actually a hormone, not only a vitamin.
Correct.
And we will discuss about how important it is too. Okay, a patient started Yasmin at age 42 after diagnosis of premenstrual syndrome. Now she's 50 and want HRT. How to proceed?
Switcher from Yasmin, it's not very ideal at age 50 because probably she's getting not enough hormones from Yasmin and she's symptomatic. So you can switch her at 50 still. If she does not have any contraindications, you can still switch her on an oral product if she wants, or on a classic HRT. But like transdermal estradiol and micronized progesterone capsules. But still at the age of 50, she can, if she does not have any contraindications, no thrombophilia, no risk for thrombosis, she can still benefit from an oral therapy, HRT.
So in this case, for example, 42 years old with PMS, what would you have prescribed her? Would you have prescribed her Yasmin?
42 with PMS. So at 42, no, I would have not prescribed her Yasmin. So probably Yasmin I would prescribe before 40, not after 40. I would go with these products which are designed for perimenopausal women, and we have quite a few. We have maybe it doesn't fit the names in your countries, but we do have Angelique, we do have Cicloprogenova, Cycloprogenova, we do have Clyra. These are oral products. Of course, not all of them are contraceptive, but you need to see what the patient's preferences are or needs are and choose the correct product. But these are products which function well in perimenopause because even they are synthetic, I prefer them versus the bioidentical because they really control better the periods, and you cannot have surprises with the patients having irregular bleedings. While with bioidentical, you may have surprises and then the patient is not content. So
But for
for a
example,
couple of years, it would be good to have some of these standardized products with a perimenopausal woman.
if she didn't have any, so she said she had only premenstrual syndrome, so maybe only progesterone in the
So,
middle.
yeah, could be an option. Only progesterone if she does not want contraception, if she does not have cycle irregularities, progesterone even only for 10 to 12 days during her PMS period could be enough.
Yeah, this I would start with this.
Yeah,
That I want.
yeah, definitely.
In the case of hysterectomy, what is the best HRT for a menopausal women? So,
Classical, it's estrogen, but it can be also estrogen plus progesterone, even if she's hysterectomized.
mhm. Yeah, we had there a question about if the patient does not have uterus, if we should use progesterone. I said my opinion is I always give them progesterone for the other benefits in the body,
Right.
even if she
Yeah.
doesn't have the uterus. Like what do you think about that?
Yes, definitely. Yes, it's even for the breast, it's protective, and also for relaxation, sleep, anxiety. Yeah, so it's beneficial. Maybe a lower dose as if she would have the uterus. You don't need to give her a high dose. But in the majority of cases, even hysterectomized women benefit from a bit of progesterone.
Yeah, like lower dose, you mean like 100 milligrams?
Oh, even lower, maybe 50, 80. If it's compounding, if it's bioidentical, you can play with the doses. So not even 100, no, not lower even.
So someone asked about the if we use progesterone oral or transvaginal. So use it oral for the systemic indications, and you use transvaginal when you want to increase, I don't know, for the pregnancy or for things in the uterus or to protect the uterus, right?
Vaginal progesterone is also efficient for endometrial protection if it is inserted very deep, like in the third distal portion of the vagina, not middle portion, not proximal portion. Deep, it protects the endometrium. I think it is a safe way of administration. I only see the disadvantage of long-term vaginal usage of progesterone. It's not very comfortable. So many patients complain about not having comfort in using every evening a vaginal progesterone capsule, but they are efficient if inserted correctly and do offer endometrial protection. While if you want to give them for sleep, for example, I would not advise them intravaginally because they would not have other systemic effects if inserted vaginally, only endometrial protection.
Um, I have 44 years patient with history of hysterectomy and oophorectomy after complete mole. So the patient is 44 and her oncologist refused HRT.
Mold,
Yes,
I don't see any problems here if it is treated.
hysterectomy, yeah.
So what would be the contraindication? I don't really see. It's probably an uninformed doctor. As I told you, patients like told by doctors who don't know nothing about HRT, they just think, oh, why complicate things? But it's better to tell a patient, look, I'm not an expert in this field. I don't know. Go to somebody who knows, who has done this training in hormone, and see what he tells you. And then you can come back to me, and or we can counsel both the patient. But if you tell the patient out of nothing that she doesn't, she has contraindication in this case for HRT, then you really can destroy the patient.
Yeah.
Yeah.
How do you check estrogen level? Circulatory or metabolic urinary level? For example, 2,16-hydroxyestrone.
So in blood, in serum, you can test just total estrone, and 2, 4, and 16 IOH estrone, you will test them in urine. You cannot test them in blood.
Okay. What progesterone in evening? Micronized progesterone, natural progesterone. For how long did you give her? I don't know for what the patient is, about which patient, but usually you give her for as long as the patient wants and feels good, right?
Right. Yeah. Yeah. There's no limit actually at present, no limit for the cessation, interruption of HRT therapy.
Okay. Other things about doses and administered duration. So it's about this we'll do in the course, like because it's about the patient. You cannot tell every patient the same thing, give her the same dose. For some, you start with 0.3, some you start with 0.5, like estradiol. Some you start with 1, some you start with combination estradiol with estriol. Some you start with estradiol with estriol with testosterone, and add oral progesterone. Oral progesterone can be like 50 or 100 or 150 or 200, depending on the symptoms and on her hormonal test and her age and contraindications.
And
So
on how much estradiol you would give her.
yes,
So
this is why we don't like tell you now exactly like this is the dose, because it's an art. And in the course, in the like 4 days, actually like 2 and 2, you'll manage this art because you see so many cases that then you understand, oh, for this kind of patients I will do this, for this I will do that. By the way, some other doctors registered. Congratulations, and we're going to see you in the course. Okay, so we have now, maybe we stay like 10 minutes to answer a couple of questions. During this time, you can still register on the link. 62 years old, menopause at 40. Osteopenia, what to do? What can help, if at all? She had Livial in early, like Tibolon, in early
mhm,
menopause for 1 year.
mhm.
Some other thing, a doctor asked us about Tibolon as well. Yeah.
It's a good option as well with this patient because she's already 22 years in menopause. If she has benefits, I mean, relief from Tibolon, then Tibolon is a good option further. Um, what could happen is that she has symptoms like hot flashes, for example, which are not relieved by
Osteopenia.
Tibolon. I
Osteopenia.
know, but I'm just talking about some scenarios. What could be a no-go for Tibolon if she, because I had a patient like this. She switched on Tibolon at age 70, and then she got hot flashes and she couldn't follow with Tibolon anymore because it didn't relieve her hot flashes. Although, of course, the indication was good for osteopenia. So we switched on patches, I think, something which relieved her hot flashes. So upfront, Tibolon would be a good indication for this patient, but let's see how her symptoms develop. If she would have symptoms which will not respond to Tibolon, then you will have to think about another option. Or libido, for example, is not addressed at all by Tibolon. Yeah.
Some doctor ask if we use DIM and creatine monohydrate, probably for the patient with acne, maybe, or yeah, we
Yeah,
use.
DIM and creatine are DIM is a very good estrogen metabolism protector. So and creatine is very good first thing for the muscles. And if you take a higher dose, then it goes up to the brain as well. But normal dose is just for the muscle, because muscle are really very greedy with creatine. They get up to 5 grams of creatine is going only to the muscles, no brain. Over 5 grams is going to the brain, maybe. But regarding this patient with acne, I don't know. You have to see her hormones first. You have to see if, I don't know, if she's has a PCOS maybe, or she's metabolizing through aromatase to DHT more, or she has more DHEA. DHEA in excess can cause acne. Or
Insulin
she has a
resistant.
lack of zinc. I don't know. You have to see her labs and
Mm-hmm.
optimize her accordingly.
Yeah, and we'll discuss about a lot of lab tests that usually as gynecologists we never recommend.
Yeah.
So before I started some years ago with the hormonal courses and longevity, I didn't imagine that some things we can test in the blood and we should. So yeah, we'll discuss about that. So I need, yeah, I'm using creatine monohydrate, and I always tell my patients as well. So yeah. What is the role of cortisol in all regimen of HRT? Yeah, we're going to address that in the advanced course as well. Cortisol is very important. It depends on how most people just take it in the morning and that's it. We will discuss about how to take it during the day, in the night, to understand the curve, right? And the importance of the cortisol. Okay. Any role of oral estrogen tablets in the absence of transdermal estrogen?
Role.
Yeah, yeah, they have role.
It,
Yeah, of course.
it's an option. It's an option up to, without contraindications, of course, up to 60, you can recommend oral estrogen. After 60, the basal thrombogenic risk for a woman is raising naturally without any hormones, so due to her age. And formally, after 60, no oral estrogen is recommended
Mm-hmm.
further.
Menopausal 56-year-old from 5 years in menopause, hot flashes, fatigue, sleep disturbance, brain fog, depression. Investigated and found very with extremely high estrogen after femoston. I excluded estrogen therapy but started progesterone, pregnenolone, and DHEA keto. Patient improved in 3 weeks dramatically. Can I still consider estrogen in 3 months?
Yes, you need to test again, but normally femostone is not detectable in blood. Femostone is a synthetic product and it's not detectable in blood. So you might look up maybe other sources of estrogen production in her body, not the femostone, in my
Yeah, like
opinion.
from the fat or from the adrenal.
Yes, fat adrenal, some ovarian cysts. You need to see to check her up where this estrogen is coming, because it's likely not femostone.
Mm-hmm. 53 years old, menopause for 4 years, complain of joint pain and fine tremors. She is known case of polycystic kidney disease. How to manage?
Transdermal estrogen is not impacting her cystic kidney. So you can evaluate her, of course, and so on, but you can start her on transdermal estradiol.
Okay, and I think we're going to take the last question, like what investigation to be done before starting HRT, how to follow, this is the chapter of the course, how to follow up and optimize hormonal levels. Yeah, exactly. It's another chapter of the course. Can
Yeah.
HRT be safely given to patient whose sister died of breast? Another chapter of the course to discuss. And she didn't have her BRCA gene, BRCA gene testing, and now has uh, brain fog and hot flashes. Yeah,
Mhm.
this is a very long discussion. So investigations are a lot. You'll get this in the course. Like you'll have
But
this.
this is all addressed in the beginner's course. Everything what you asked now is addressed very clear and very detailed in the beginner's course.
Yeah, like it will take us about like 3 4 hours to to answer your questions. But For example, let's only address this part. Like if her sister died of breast cancer and she didn't have her BRCA gene testing, what would you recommend? Like,
So she's definitely at risk for breast cancer. With or without BRCA testing, she's at risk because she has a first degree relative with breast cancer. On the other hand, she has no contraindication for HRT, either with BRCA or no BRCA testing. With BRCA testing, you need to, it's not mandatory before starting HRT. It's a patient's option, and it's a very responsible decision to take and to discuss with the patient to take or not the BRCA testing, because the result, she should know how to manage, how to deal with the result. So what is she going to do if she's BRCA negative? Does that mean that she's not going to have ever breast cancer? No, that does not mean that. This doesn't reassure her. If she is BRCA positive, is she willing to take then the prophylactic surgical interventions like bilateral mastectomy, bilateral oophorectomy, yes or no? So this is an issue which probably you as a gynecologist need to address with the patient, then send her to a genetic specialist to discuss in detail this, because taking the BRCA test is easy, although it's expensive, it's easy. First, they're not the only genes responsible for breast cancer. Nowadays, we have a much more extensive gene panel for breast cancer risk. So BRCA is nothing anymore. And second, she should be aware of what will she do after having the result, if positive or if negative, and then decide. But this is a complete different story. She can take HRT, nevertheless.
and another patient with hormone-dependent breast cancer, 55 years old, taking anastrozole. Is this a contraindication?
So if she is treated and she is not having surpassed the 5 years after treatment, formally she cannot take HRT. So after 5 years of after completing the treatment, if she is okay, you can start discussing HRT with her. During the first 5 years post-treatment, formally you cannot give her.
Okay, great. We still have a lot of questions, but yeah, we're going to address all of this. We'll have during the course. It will not be only about estrogen and estradiol and progesterone and testosterone and that's it, but it will be about all this and a lot of cases in details, and you'll get like homework, and you will need to come with the answers after you make the first we'll have like a combination, some theory and then some cases. So in the cases you need to write the prescription, then you're going to discuss with Dr. Hera about why you wrote the prescription like this, what can be optimized, what to add, how to monitorize the patient, what to recommend after that. So thank you all.
Yes, and then we will also have at the end of each day, we will have Q&A sessions where you again can come up with clinical cases or other questions. So it'll be really very interactive. And I think there'll be a ton of information for you, really valuable.
Yeah, exactly. It will be a lot of things we're going to address about all this like longevity things, and I'm so happy that you are interested to learn more. Of course, you'll get a certificate about this and about how to and everything, like all the materials. You'll get a lot of materials to help you in your clinic to start right away with having good information for the patient and for the staff, and about there were some questions about compounding pharmacies. We're going to discuss about that and the differences between them and so many more. So congratulations for this evening. I know it is late, probably I in different countries is even later. I really appreciate that you were here with us, and happy Easter for everyone who will be celebrating last.
Celebrating. Okay. Thank you so much, everybody. I hope this was valuable for you and you got curious about learning more. And I'm looking forward to meeting you in the course.
Yeah, so remember, just you still have a couple of hours to register. Good luck and hope to meet you more, like to have a closer relationship where we can help our patients. Thank you. Thank you so much. Good,
Bye.
bye. Good night, everyone.